because there's lots of discussions taking place. Right. There may not be as many people on here as we'd like. However, it is being recorded. It goes out. Everybody does tend to report back and say, we've watched it. Sorry, we weren't there. It isn't the best time of day. But actually, what's really nice is that all of us anyway can follow and track what's going on. So I'll just do a very quick introduction. I'm Anna, as you probably all know. I am the development lead for the Dorset Care Association. Andrew is down at the bottom on my screen. I don't know where he's on anybody else's. He's one of the directors of the Care Association, so it's nice to have Andrew on board. Hannah is the admin, so Hannah's making sure that there's no spitting or swearing, because you know what you lot like. We'll just cover a few things today. The agenda's gone out. Christiana's jumped in last minute, which is great, because I was going to try and talk my way through the new delegated health care activities, and Christiana I saw just now said, can you come and help and talk about it, because I think that's going to be quite interesting and how it may or may not affect some of us. So in terms of moving forward, I think I'm going to hand straight over to Derek. Derek's going to talk briefly about home care optimisation, the way forward, and how it may or may not affect us, and anyone who's interested in joining his merry gang.
Okay, thank you very much, Anna. I'll try and be short and sweet. I'm vertically challenged, but nobody has ever described me as sweet. So thank you very much for the opportunity to come and have a chat today. I'm very pleased it's being recorded, because we are doing as much as we can to create wider awareness and interest in this work, and that will help us enormously. I've also got colleagues on the call, so Sarah and Di, who are both heavily involved in this work, and I'm sure can add some clarity to the garbage that I bring out. So first of all, we did this piece of work in response to a range of challenges. We know that every winter we have pressure on the system, and we need to have capacity resilience to be able to respond to that in a way that keeps the system flow working. In January of this year, we also had a reasonably significant number of people who are waiting for a package of home care. That was 270 in January. We were using some of our reablement capacity and short-term recovery focused support to deliver ongoing home care, neither of which is a good use of resource. And we had around a third of our packages of home care going off framework, so those people who don't have a contract with Dorset Council, and we wanted to actually sort of build the sustainability and resilience of our contracted providers so we can support them to grow and develop. We also knew that our brokerage process was taking quite a bit of time and didn't encourage collaboration between different providers. And more broadly than that, we know as a rural area that there are other challenges within Dorset, both in recruitment but also significant travel times for home care services. We also finally had, we've had about 1,500 people who are awaiting their annual review of their care and support. And we know that we have good, knowledgeable providers in the Dorset area that can support us in that. So what we're doing, we've got a programme of work which covers four major themes, one of which is improving our brokerage processes. Second is zonal optimization. I'll explain that in a second. Thirdly is using technology-enabled care solutions. And finally, it's implementing the principles of trusted practice. So a little bit like describing with all the great work that Chris and colleagues have been doing, but looking at that within our home care providers. The principles we've set for this piece of work is that we are focusing around the person, so that's improving outcomes, but also the balance against the commercial interests about making sure we're making best use of taxpayers' resources. Making sure that we are open and honest and consistent with all our communication. And I think Anna would echo this. The sorts of feedback we've been getting from people is very strongly we're achieving that. Making sure that we have a balance of our commercial interests, but also ethical and legal considerations. So this is something can actually be embedded as part of ongoing change. We work heavily on the principles of co-production and partnership. We want to have a strategic partnership with the provider market, not just for this piece of work, but more broadly. And again, I think that's actually paying dividends. And finally, we work from the basis of evidence, and we are data-driven in focusing where we can achieve the best impact. So I won't drill into some of the benefits we expect to achieve from the programme, because otherwise I would be less short and less sweet. But just when we're in terms of where we're at with the brokerage process improvement, we listened to a number of providers and Dorset Care Association about what was wrong with the current arrangements, and two things shone out for us from that. One of which is the completeness and consistency of information available at the front end of the process, so people can make an informed decision about bidding for a package of care, and also they have the right information, so when they start a package of care it runs smoothly. Basic information like who to contact, how to get access to the property, are there dogs on the property, or other environmental risks they need to consider. The second part was the amount of time we waited until we went off framework for low complexity cases. So we have reduced that time, so we increase the potential for our contracted providers to be able to deliver that care and support. We're already getting some feedback of some improvements with the arrangements that are taking place, and we're expecting that the process changes that we make will have an impact on reducing it takes to place a package of care. Zonal optimization is a very jargony word for saying bring providers together and use data via a GIS map to help people understand how they can optimize their existing business arrangements. By doing this, we have engineered some swaps of packages, some transfer of packages back from off framework to on framework providers, with the aim of reducing drive times, eliminating rota gaps, and allowing more care to be delivered without increasing delivery resource. That's been quite successful. We trialled it in Dorchester and West Moors, and we were able to move a total of 38 packages across 2 sessions. That's quite a significant achievement. It's not all rosy, because some people who were going to be swapped between providers objected strongly to that. So it's inevitable that's going to happen. That was 6 of those 38 that objected strongly, and we didn't force the move. We didn't do that because historically, when those individuals initially took their packages, they weren't aware there may be some changes. So we're now looking at creating a policy statement which will make clear what is the reasonable expectation of a package of home care in Dorset. We are now in the stages of looking at rolling out that programme, and we've got the next target areas which we'll be communicating back, and we'll go like we did before. We will have some conversations. We'll meet with people face to face to make sure they're prepared and ready, and we have a successful optimization session. That rollout will happen between now and July. We can see some wider benefits of a lot of this work that I'm describing to you today, and if there is broader interest from other provider groups, we'd be delighted to come and actually have a conversation in more detail. It will be particularly applying to the next 2 categories. One is trusted practice. So this is seeking to do a number of things, but we know that we've got 1,500 reviews which are outside of the Care Act 12-month timescale. We also know from speaking to providers and from experience of where this has been applied elsewhere that some packages are overprescribed, and there is the potential to change those and make use of that spare capacity. We also know that some individuals have an increase in their care needs, and not responding to that may present risk at them staying safely in their own homes. So what we're looking to do is to delegate the council's authority under the Care Act to undertake the annual reviews to providers. This will be providers who are good or better on CQC, have no quality assurance red flags, and who can nominate an assessor who has demonstrated experience of training with Care Act eligibility in the last 12 months, and also they've had training in relation to the application of strength-based practice. We've got 4 providers who are helping trial this in the Weymouth and Portland area, and we are training those assessors in the use of the assessment documentation, This will be using identical documentation to that used by the council in its Mosaic system. And that will then be, and after they completed that, the trial will start formally with reviews being undertaken in the week commencing the 5th of June. We're going to run for an initial period of 6 weeks, and we will quality check every review in that time. After that, we will then delegate further authority to make changes to care packages within parameters we set from phase 1. After that, we've got a wider rollout based on knocking the rough edges off process design, making sure the technology works as smoothly as possible. And as I said earlier, this has got much wider potential application across other care categories. We're going to do the, sorry, get on to the next one. Start again. Technology enabled care is the final part. And again, I think this will have a much broader level of interest. So we know from experience elsewhere, and as I was saying to James earlier, we know both across adult social care and health, the use of technology can have a significant impact in supporting how people's conditions and their social care needs are met. We know from evidence elsewhere that this can enhance people's feeling of independence and control over their lives. We are looking to trial a piece of technology called Ethel. If there is interest, I have some videos of Ethel in use, which I'm very happy to share. But we have again selected a number of providers across Dorchester and West Moors. So we've got two fundamentally different geographic challenged areas that will trial this starting from Monday next week. It's gone through a prep stage where there's been awareness, operational training for the staff that are going to be using it, engagement with the clients, getting consent forms completed. So it's been quite a piece of work, but we are now ready to do that trial. We have got some spare units of Ethel and would be interested in speaking to other providers, either within home care or on a broader basis, that we could look at considering whether there might be an application of this technology. So open to contact. It's an invite for expressions of interest at this stage, but I think there is much greater potential and we need to actually think about how that will fit with our trial approach, but would very welcome the opportunity to speak to people. We're going to run our trials for a period of 8 weeks. After that, and we're capturing the information both using the survey function of the Ethel unit, which asks a couple of very simple questions. Are you happy using your Ethel unit, and are you happy to continue with it? So we ask very basic questions, and then we've got a broader set of questions which are both for the provider and the client to ensure that we've actually captured qualitative and quantitative information to inform a decision about how we may take this forward in the future. Sarah, do you want to come in?
Yeah, I just wanted to sort of noticing some of the chat and kind of our ambition to sort of look at how this programme can support other areas, so in particular obviously supported living. I suppose it's just to say that, just to emphasise that we are still obviously in the pilot phase, and what we want to do is make sure we don't go too fast too quickly. So we want to kind of really make sure that we get this programme done properly across the older person's home care market, and then we can start to have a look at and have those conversations about how this could work in the supported living setting, acknowledging that the markets aren't exactly the same. So we just need to look at how that might work, and also make sure that we've really taken the opportunity to learn the lessons properly from the implementation of the first drive. So I really don't want providers to think that we're not keen and committed to roll to other markets, but we don't want to do it too quickly, and because we just don't want to miss the opportunity of really kind of getting it sort of cracked first time, I suppose, when we get ready for the other markets.
I think that's really, really valuable information, because actually a lot of the time we just run with something and go, and this is, you know, softly see what happens, report back, let another group dip in. So I think actually it's something that I was just saying to Vicky, does the LD gang want to hear about it? And we both think that'll be really positive for them. But it doesn't necessarily mean it's going to happen straight away, but it's informing people that this is what's going on out there. And as Derek's saying, for anybody to dip in and say, I'd like to have a go at that, I'd like to be considered, particularly for the Ethel side of things, to see what she's really like.
And I think it's a really good point that that Sarah's made, because say at the moment we'd be very interested in starting that conversation. We started conversations with other providers back in January about this overall program of work, and the more work we put in at the front end to actually sort of increasing that awareness and building the relationships will help us as we move forward. But as Sarah said, we're expecting to get results from this trial. We'll build that over the course of the next 8 weeks.
Yeah.
And if we can do some planning, if we've got the confidence of it that it can be applied in a way which is both commercially viable and also operationally effective and safe, we've then got a basis for thinking about a programme for the next stage.
And I think there's also something for us to think about in terms of, so where we are in the position where we've found that it has been appropriate to move packages of care between providers, or indeed from non-framework providers to framework providers. Actually, I think we would like to do some follow-up with those individuals just to make sure, just to understand from their point of view, how did that transfer go? Obviously, it's been we're sure it will be successful, because that's one of the key drivers, but to actually kind of capture some of that information so that we could potentially use that to support some of the next batch of conversations with other people that would be looking to move, so we can just kind of smooth that out, I suppose, and allay any fears and concerns that those individuals will be having.
Yeah. Vicky, did you want to say something?
Yeah, I just wanted to, I think it's a great idea for you to come and talk at the Learning Disability Forum. I do think it could throw up some questions, Sarah, for the local authority, if I'm honest, and we would need to be probably mindful that people would be worried. Some providers will be very worried about it. If they do then talk to families of people supported, it could throw up questions from families too, who would naturally be worried. So I just think we need to go very carefully and say it's not on the cards right now.
Yeah,
and I think that's why starting it now, when it's just a pilot, and saying this is what's going on, a bit like Pam's, we were able to kind of work our way through it and say, and we can feedback as we go. I think that's, but you're right, Vicky, of course it throws up questions. There's a fear of, does someone become lonely because I've only got Ethel? But actually probably not, because there's other stuff going on. Is someone going to have 20 packages wrenched from them and given to somebody else? So yeah, absolutely, all of that needs to be.
I think it's about, sorry Derek, I think it's about doing what's right for that market. So whilst we've got 3 strands of the home care optimization project for older persons home care, actually it might only be appropriate to have 2 of them for a different market, or to alter that work stream a bit or what have you. So sorry Laurie, I jumped in front of your hand. I do apologise.
No, it was actually Sarah. I was going to say, we've recently experienced where, as non-framework providers, 3 of our care packages have been taken away from us, which is absolutely fine, but the impact on those clients was horrendous, because they received a letter saying they were getting a new care provider. We, on a Friday afternoon, we as the existing care provider knew nothing about this at all. It hadn't been communicated with us at all. We had a conversation with Simon Fielder, who'd we acknowledged we were off framework, did not want to join the framework because of the rates. And then these packages were taken away, and we had so many calls from distressed clients saying, this has happened, we don't want to lose you as a provider. The whole transition has been handled appallingly. Okay. And we know this has happened before, and we know change has to happen, but it has to be managed properly so that these clients aren't distressed.
That's very helpful feedback, Laurie. The process is meant to be, where we've identified that there is a change possible, that we first of all will engage with the individual and their families to talk them through that, and then that should then be communicated to existing provider, in this case yourself, and then the transaction gets made. So if that's not happened on this particular occasion, then our apologies for that. And that's helpful feedback, and I'll take that back into the system.
Sarah, can I make a suggestion? Because actually that's actually really positive in one way, because what it's done is it's actually got straight to Derek by having this meeting. Can I suggest that goes offline for you two to have that discussion in depth, because it's important, and it gives Derek and potentially Sarah the opportunity to discuss it further and see what went wrong and what lessons can be learned from that. Is that okay?
That's absolutely fine. Thank you.
Brilliant. And thank you for bringing that to his attention. Is there anything else around that, Derek, that you want to raise, or is anybody else thinking, oh, I'd quite like to have a go at that and put my name forward? If you are, you can let Derek know directly, Sarah or Hannah or myself, and we can filter that through to Derek and his team.
So the other thing which on the technology enabled care, which again we need to be careful as at the pace we go, as Sarah's correctly said, but there is much wider potential. We're scratching the surface of the use of technology in care, and so the devices that we are trialing have got the potential to use wireless peripherals. So if somebody has health related needs, they could actually use, have routine wireless monitoring of blood glucose levels, their SpO2s. So there's a whole range of things that could be done, and we have much wider potential. And separately, I'll have some conversations with health colleagues as we start to get some results through about how this may strategically be an opportunity or something which is joined up across markets and also other partners.
Brilliant. I can see Chris from the TAs has also said, can you send a link on Ethel? And actually, I see, and I'm sure the trust assessors do, potentially the link in terms of, the kind of discharge processes as well, where they could support with that as well over time. So hopefully we'll all link, which actually takes us very nicely into Mr. Burry, who, as many of you and most of you probably are aware of what a Medicare is. And if you're not, I'm sure James will give you a very quick talk on it. But this isn't about what it is, it's about what it's achieving. Because being part of it myself with another couple of providers and listening to providers across the whole of Dorset, Bournemouth and Poole, it's really successful. So it was just to give you an update, really, and for James to show off.
Thank you very much. I'll do my best to show off. Right, so I'll just quickly share a presentation because I've got a few facts and figures on how we are doing. And is that going to work? There we go. Hopefully you can see that. Right, so what is Medicare? I promise not to talk about this too long in terms of how it goes, but basically we give care homes a laptop and video camera, and they can then call a telemedicine service 24 hours a day. The nurse in that service can see the carer and they can see the resident, and likewise they can see the nurse, and basically they can assess and where possible treat the individual. We were given enough funding by NHS England to do a one-year trial for up to 77 homes. As of today, we're expecting our 70th home to go live. We have 6 homes who are awaiting training, and we have 1 home who's been trained, but they've got some severe sort of Wi-Fi issues, which is stopping them going live in the minute. So, and there's also 4 homes on the waiting list. So we're pretty much at the sort of top capacity of where we can go. These are the sort of numbers of calls we've had. So throughout this, the blues are nursing homes, the orangey colours are residential homes. The light colour is sort of in normal hours, and the dark colours are out of normal hours. So basically what we're seeing there is an increase in calls over time. Interestingly for me, there's more calls coming in from nursing homes than residential homes. Now, in terms of the number of beds being covered, there's pretty much an identical number at the minute of residential and nursing homes. So there's a little bit more need for help coming from the nursing homes, which on the one hand, I suppose shouldn't be surprising because they're more complex residents. But on the other hand, I was wary or nervous, I guess, really, that nursing homes may be reluctant to seek help from fellow nurses and therefore not use the service very much. But that isn't the case. So I'm really pleased to see that. Also, what we've got there is in terms of in hours versus out hours. April was really interesting. So double the number of calls were being made out of hours than in hours. That may have been partly due to Easter and disproportionate number of bank holidays, but a significant number of the calls are being needed out of hours. And in terms of the time of day when we're getting the calls, now this is across all 7 days of the week. So two-thirds of the calls are out of hours, so even the daytime, some of the daytime calls are coming out of hours. But you can see that there's a reasonable volume of calls in the evenings and early morning that are being picked up and dealt with quickly rather than waiting, say, till the daytime or till the main week begins before people are actually seeking help. So that indicates that we're getting help to people quicker, which has to be good. In terms of days of the week, Saturday and Sunday are the busiest days, very clearly. And again, possibly linked to Easter, I don't know, but anyway, we'll see as we get more data, but this is up as far as the end of April. Why are people calling? Right, this is a little bit hard to see, but I'll just point out some of the highlights. Far and away, the biggest reason is falls. So 80 calls in April were for falls, and that's more than 3 times the next biggest reason, which was possible UTI, and then chest infections, deterioration, localized infections, and meds issues. So again, blue is nursing home, orange is residential. But what's also quite interesting here is there's a number of areas where you've got particular issues are being phoned up by residential homes but not nursing homes, and particular issues are being phoned up by nursing homes but not residential homes. So we'll have a little quick look at that to see what the reasons are. And again, for April, the top reasons for calling, so all the ones in black type, so again, falls, UTI, chest infections, those are pretty much the same across both. They're where both residential and nursing homes are calling a reasonable number of times. But where we're seeing nursing homes calling that we're not getting these calls from residential are issues around breathlessness, catheter concerns, pain management, and sort of query TIA or stroke. Conversely, with residential homes, the calls they're making that nursing homes are not making are around head injuries, end-of-life symptoms, agitation and confusion, and bowel concerns. So just a little bit of difference there between them. Significance of that, I guess we'll investigate later, but it just shows that the support required from the different types of homes is not the same. When homes call to Medicare, they're asked what would they have done if they couldn't have called to Medicare. Most people would have called the GP, which is fine. The next big category is follow-up calls, so we're not including those. But after that, the next one is they wouldn't have sought help. So I'm guessing they would either have waited for other colleagues, or maybe they'd have waited for a reward round or something before they raised it. But it does indicate that these people are getting seen a lot quicker or looked at a lot quicker than they would have done if without this. And some would have just either taken them to A&E or called an ambulance for that. So that's what would have happened there. Now, calls that would have gone to a usual GP, this is the green in total. So this is the total number of calls they're getting by different times of day, and the light green is the number of calls that would normally have gone to the GP but actually went to a Medicare. And the darker colour, the blue, is of those calls, how many ended up going back to the usual GP anyway. And what we had here is, I think it's 77% of calls were resolved that would have gone to the GP without having to go to the GP. So that sounds great news for the GPs, that they're getting less calls. But why is that good for the care homes? Because it's really important to make urgent calls for help if they're needed. No, I don't want to say don't do that. Well, it's really important. But from an operational viewpoint, it's very disruptive to the GPs if they need to sort of basically stop their surgery, come out and check someone, and then go back. It leads to delays and backlogs and things like that. It's necessary, but it's not ideal. What this does is it allows a lot of those calls to be dealt with faster, because the GP can't just drop everything and come and have a look, but also without disrupting the GP so much, which gives them more time for their routine and planned care, which means more prevention of illness. So it's good for everybody if we can get that in, because prevention, as the old saying goes, is definitely better than cure. Not all calls get through. Sorry, not all calls are dealt with. So just under half end up being referred on somewhere else. Some, as we said, do go back to the GP, the usual GP. Quite a lot are going to the out of hours GP, so that's the overnight and weekend service. And very often that is for issues like scripts or seeking medication review. As you know, by far the biggest reason for the calls is falls, and where they can, they will always review the medications of the resident who's had the fall, just in case there's something there that might be triggering it or sort of contributing towards it. In Medicare, only deal with the acute needs and the urgent needs. Anything around routine issues and routine medication has to go back to the doctor. So if they've looked at one of these falls and think these meds need to look at, they will always refer those back to the GP. And the other thing that's happening there is just issuing prescriptions. They've only just started in April to be able to issue their own prescriptions. That they can't do it for every case because they haven't yet got enough staff to do that for everybody. But they can issue prescriptions directly to your local pharmacy, which means you can get the medications much quicker, you can start treatment much quicker. And we had a case study recently, which was actually raises concern around some delays that subsequently happened. But basically, even though they had to wait a while to get through on the call, they had a script ordered within an hour of the call for someone with an urgent UTI. So that side of it worked really well. What didn't work so well, unfortunately on this occasion, was actually getting that script to the pharmacy. There was some issues we had with 111, which are being investigated still. But basically, now that they can issue scripts directly, in theory, you could be calling them and within 45 minutes, an hour, there's a script on its way to the pharmacy and treatment can start soon after. So that side we're really pleased with. All the calls come in, so basically 90% of people remain in their normal home. Again, a really good thing. We're talking about reducing admissions, reducing conveyances. This is great. And part of what's helping with this is that if you go straight to 111, they sometimes have protocols which require them to take someone to hospital for assessment, even if the paramedics themselves don't believe it is necessary. It's part of the safety protocols. Within Medicare, they take full clinical responsibility for that individual, and they're able to make decisions around whether they should or shouldn't go to hospital. And certainly when you're looking at what the advanced care plans are and the like, they will try and keep people at home wherever possible. So one of the other reasons I'm here today is I'm asking for help, because if homes are participating, what we really want is feedback from them. Whether it's good or not so good feedback, it's very, very helpful to us, because even if you're saying, well, this can't happen or this can't happen or it's not going great, that helps us design what's important for the future. This is a pilot. We're trying to develop systems that will support care homes more effectively in the years to come, not just during this pilot. I really need examples of where it's worked well. We want to argue for additional funding to support more homes and to support it for longer. At the minute, we've got funding till end of February, early March next year. But it'd be really good to extend that, because all the feedback we're getting is that it's really helping. But we need examples of that to do that. And also a bit of mutual support. So some homes use it a lot, some homes don't use it so much. What we've heard is that some people may not need it, which is fine. Others don't have the confidence about using it. So if you're talking to other colleagues who are using the service as well or have access to the service, do encourage them to use it. Give them examples of where it's helped you out, and it might encourage greater uptake. And yeah, some of that usage, as I say, is around confidence. They do also offer additional training. So if you want the training on how to use the system, that's absolutely fine. They can redo that for you. And they've also offered for one of their senior clinicians to come and do a face-to-face visit to your home to just talk it through and explain it. And that, I think, would be really helpful. I think if all 77 take it up, that it could keep them pretty busy. But if any homes are interested in having that, just let us know. We're really happy to arrange it. And for homes who aren't taking part, if this is of interest, please let me know. Just write and say we may get some extra spaces. I don't know. It's sort of at the low end of likelihood right now, but we've got 4 on the waiting list. I think we'll get them on board. We may get some more. But please ask. Tell me why and how it might help you, because again, even if I can't get you in straight away, this is useful ammunition for arguing for extra funds to provide extra support for care homes. And again, examples where you've had of where this might have been useful for you and might have helped avoid delays or admissions or deterioration that wasn't necessary. So I'm going to share this with Hannah so that we can have a copy of it for everybody, but my email's there. I'll put that in the chat as well. Do get in touch, do feedback. We really need that to make the most of this. Thank you.
James, I'm going to answer a couple of questions as well. Sarah, James has been at many, and I have to say a lot of people are very aware of it now and are desperate to access it. In terms of the feedback, it is fascinating. I think a lot of the residential care homes would say, isn't that interesting that the nursing homes are calling more than we are, because we're doing an awful lot as residential care homes, which is, and I mean, Martina and I have talked about this before, we're literally on the cusp of being nursing homes ourselves in so many ways.
Yeah.
So that's really interesting. And it may even start to roll into what kind of specialisms care providers are able to offer. I was going to ask, are there many LD residential care homes using it yet?
No completely LD homes, and I don't think very few who are mixed, very few, so a tiny minority, I'm afraid.
That would be good to find out why and to push more.
Well, the why I know, which is this is part of what we're trying to develop for frailty virtual wards, and this is a subset of it. So it's aimed more at the frailty. That's what the funding was given for. But I think if it demonstrates the value of this type of service, Medicare themselves can support LD homes. So if we can get the funding, we would love to extend it. Yes.
I think it's a no-brainer, and I think from Mel and all of us, that what we've heard and what we hear from all the homes using it, we will get as much feedback as we can to push this project forward. And I think also in terms of home care, them having a laptop or a tablet they can go out with to a client who's not feeling brilliant. Can I open it up? Does anybody want to ask any questions? I know Vicky's put some questions in there, haven't you, Vicky?
Yeah, I think you did answer them though. I didn't know if your project or pilot was extending outside of Dorset.
Right. So Medicare have been running this service for 10 or more years, and they are operating in different parts of the country. I think they're currently in 9 counties at the minute, 9, 10 counties. So I know they're in Cornwall and Devon as well as us. But I think people tend to come on short term, so maybe 2-3 years, and then try and put in their own solution. Within Dorset, we're open to that, but the reality, I think, is it's pretty hard. Well, I'm probably preaching to the converted. It's pretty hard to recruit staff to Dorset because the housing is pretty costly, and these are not necessarily sort of super paid jobs. So we're quite grateful that we're able to get additional clinical support from outside the county, because certainly the GPs and the hospitals are all finding it really hard to recruit nursing staff.
I only wondered because we have residential homes in Hampshire, Southampton, and all over Hampshire actually. But Anna already asked the question. We're a LD specialism provider, so they are residential homes for people with learning disabilities. Yeah. So
it may be available in Hampshire, because I know Hampshire had some involvement with it, I think, but I don't know if they went for it or not, or if they've used it and gone on to something else now. But yeah, it may be worth looking at.
Thank you.
James, I think there is a real keenness for all the other areas to be able to access it, and as Mel's just said, if we can have a specific webinar where we kind of talk it through, and if we could even come up with suggestions of more pilots, the more we can do to help, because it would just make such a difference to the home care teams, to everybody, the supported living teams. It would just be life-changing for everyone, and ultimately for the client, wouldn't it?
Yeah, I totally agree. I mean, it's very much the direction of travel. The idea is that we try and treat more and more people in their own home, and it therefore makes sense that these are people's own homes, and we need to bring treatment to you and not, expect you to come to hospitals and things. Not least because we all know that going to a hospital causes then all sorts of other issues around deterioration potentially and things like that. So, and then needing packages of care. Yeah, as far as we possibly can, we can do it across all homes. I totally agree.
Yeah, watch out, trusted assessors.
We're very busy.
Any other questions on that from anybody? No. Okay, no. James, you might want to just hang around if you've got time.
Yeah, absolutely.
Christiana's going to come on towards the end, and it might be of interest as well about how that might wrap around again. We've got Sarah next, if you want to give some feedback, Sarah.
Yep, sure. Thank you. Hi, everybody. I think I recognise most people on the call, but for anybody who doesn't know me, I'm Sarah Sewell. I'm one of the heads of service for commissioning, and my portfolio area is older people and prevention. So I work alongside Karen Stevens, who's the head of service for working age adults. So there's a couple of things. Really, I just wanted to come along today, and thank you, Anna, for the invite. It's really just to come along more regularly to your sessions, just so I can take any questions, just to kind of have an opportunity to touch base with you all. I haven't really got that many updates, to be honest. There's just a couple of sort of topical ones just to share with you, just for interest. You may be aware that we've, in our kind of readiness for our CQC assurance, this week we've been through 3 days of peer review. So we've had colleagues from across the local government association who have come in and been interviewing us about kind of how we work across the whole sort of adult social care and housing space. And if you were able to give any feedback that Anna and Kate from Partners in Care, who joined one of our sessions, if you were able to give any feedback in advance of them joining our sessions, thank you for taking the time to do that. We haven't had the full feedback yet from following the peer review. We've been through sort of 2.5 days of different interviews and lots of different conversations, but some of the feedback that we have heard has been very positive. So particularly in relation to the conversations that we had yesterday morning, that Anna and Kate joined, that Vicky also joined as a provider representative, and Care Dorset reps were in the meeting as well. But the feedback and the conversation was really positive about how we're kind of working with the market and some of the sort of the infrastructure and the approach that we're using to really start to improve and strengthen our relationships. So the review team have been really complimentary about how we're all sort of working together, and some of the initiatives such as Trusted Assessor has been kind of held in really good light as a shining example of how to kind of work and improve relationships across the market. So as we have more of that feedback coming through, we're obviously expecting that we'll have some areas for improvement. That's part of doing this exercise, is to really get underneath where we're at. We'll obviously share with you our plans and how we'll be taking that forward, and we want to get a better two-way communication flow going between obviously us as commissioners and the providers. So I'm really keen to continue to kind of build that with you. The other areas I just wanted to give you a quick heads up on was in relation to cost of care. So there'll be invitations again coming out around that, but Anna's kindly hosting the launch of that. So that's around older people's care homes initially, and we're looking to launch that the week after next at the end of the week. I've written down the 7th of June, but I don't think that's right, because that's not a Friday, is it? The 9th of June. The 9th, yeah. The 9th of June, we'll be doing that launch. So there'll be further information to come out about that. And that is for our older persons care home cost of care exercise. And then we'll be doing the same exercise again for the community-based home care and supported living. We'll be rerunning that again later on, probably the late end of the summer. So they were the kind of the two sort of just topical updates that I wanted to share with you, but happy to take any comments or any areas that you would like to hear a bit more about, that we could come back to the next session. Indeed, Karen will be able to join the next session as well, hopefully.
I was going to make a comedy comment, which you all know I usually do, which was, we all know that moment when we look in the car park and say, oh my God, CQC are here. It was very much like watching that in County Hall. So
yeah, headless chickens.
Yeah, my point of view was, it's good that you've experienced it. It's good that you've had to rally the troops. It's good that you've had to take it part, because actually, and Vicky's nodding as well, and I'm sure Mel and Kate will, it's good for us to know that you're now experiencing how much we have to do in preparation for something like that, or even when they just turn up in the car park, because it is a huge amount of work, isn't it? And there's things changed. I'm going to talk in a minute. I'm sure other people will join me, probably Mel, when we talk about, you know, the single framework that's coming our way and how different it's going to be, and in terms of the feedback. And that was very much how you were operating. You were getting the feedback and sharing it. And, you know, the feedback we did get from providers was good, not so good, needs improvement, good. And it was really positive. So it was really open and really honest, and really well received by Dorset Council as well, I will say. Did anybody else want to say anything on that?
I just wanted to say that probably the same as you, actually, Anna. It's nice, as much as I don't wish it on anybody, Sarah. It is nice to see the local authorities going through the same process that we've had to go through for a long time. And I hope you all feel that it gives you the opportunity to reflect, because that's what I've always found inspections give us. It's a really good time for us to really review and look at what we're doing, and before an inspector comes.
Yeah, and it did evidence a lot more collaborative work, didn't it, Vicky and Mel? There's lots more going on where we are, I think, as providers, more aware and have more of a voice. And whereas before we very often got told how we were going to do it, there's much more of a, this is how we'd like to do it. Do you think it'll work or not? And if you don't, we'll try and work with you more. So it's definitely moving forward, which is good. I'm going to just jump over to Mel. Mel, have you got stuff that you can share with the gang?
Yeah, just a few bits. So I'll try not to bore you as usual. So just in case I don't know, there's a couple of people I don't think I recognise all names. So my name's Mel from Partners in Care. So if you're not on our mailing list, you can always welcome to pop your email address in the chat, and we can add you. So just the things to make you aware of. It's coming up to that time of year. I was just doing the newsletter earlier actually, and trying to make renewing your DSPT sound really exciting. I'm struggling, put it that way. But it is that time, I'm afraid. So just to let you know that we have 10 events running over June, and you should have got a specific email to your organisation today about what you need to do. So you might be on different kind of compliance levels, etc. And I'll just pop in the chat as well. It's a link to all our events that are taking place next month. So just a heads up about that. And if you don't recognise it at all, it's for all CQC registered providers, but can be anyone else can do it as well. If you don't know anything about it, happy to just have a chat offline about it and bring you kind of up to speed. But you will find you need it for things like any funding, access to NHS mail, proxy access for medications, System 1 access, that type of thing. So it's becoming more of a kind of commonplace thing. Just a couple of dates that are coming up. So the next Registered Managers Network is on the 15th of June, and that's going to be 10:30 in the morning, and that will be a virtual one, so nice and easy to join. And then the following one after that will be the 12th of July. That one's going to be an in-person one, and we're going to go to the west of the county this time. So we haven't quite booked the venue, but it's just to let you know about those dates, and hopefully you can make it to some of those.
Now, just to jump in, we did have a conversation just now with Kate and Christiana that potentially Dorset Care Association will do some funding for that, so that we can get more of the Dorchester and Southwest gang over and do a better buffet than you.
I was going to say, bloody hell, right? Do I need to bring my doggy bags to take everything home in?
Definitely. It'd just be good to get more people there, wouldn't it? Because we do struggle slightly our way, and then we have a bit of a whinge about not being heard. So we'll try and do everything we can to get everyone there. Yeah,
it's Dorset in the travel links, isn't it? It was a difficult one to try and please everyone, which is why we try to alternate. But yeah, that's a great idea. I'm sure Christy might mention, but WDF, so the Workforce Development Fund, which we hold, the applications have just come out. So what normally happens is we apply on behalf of this area, and then you apply to us. There's certain hoops you've got to jump through, as you can imagine. So that goes towards sort of training budgets, etc. So just to let you know, we're putting in an application for that. I think the closing date is 13th of June, something like that. And then depends how long Department of Health and Social Care take to come back to us to let us know. As you can imagine, that's how long is a piece of string, but and fourth thing was just to hold the date again, another one. So we're doing a digital conference on the 21st of September. So that's going to be quite a large scale kind of conference, and we're running that in partnership with the Integrated Care Service as well. So it'd be really interesting to get everyone together. So I haven't got any more details other than I booked the venue this week, and one thing I would really love to ask, if anyone's got any service users who's benefited from digital technology, really like to have some service user representation. So if there's anybody who's kind of found something with their clients that's kind of revolutionized their life in a way, that's helped them keep their independence or something, we'd really love to kind of showcase that, because it's all well and good us telling us and these are the stats and isn't this great, but actually how is it impacting on the people that it's kind of really there for. So I think that's a bit about it from me, Anna. I want to keep it brief, but very happy to take any questions at all.
Two things. One is, Hannah, we could do a quick shout out to the daycare providers, because some of them have got some quite good IT service users, and Vicky's nodding as well, so definitely that side. The other thing is, Mel, didn't we have the other day, we were talking about DSPT and compliance checks, and there was some shyster type companies out there charging megabucks to do a DSPT compliance check, so be careful, everybody. Don't approach them. Approach Auntie Mel, she'll sort it.
Yes, it's our time is funded by the NHS Transformation Directorate, so it's completely free, although I will say, is the expert in the area. I said to Anna last week, I took some photos of an event and accidentally sent them to a colleague at Dorset Council, and it was me in the changing rooms in Zara trying some trousers on. So so there we go. just to make you all laugh this afternoon. I didn't buy the jeans; they were terrible anyway. So
Well, they
there we
weren't compliant, were they? They weren't
go. No,
compliant
they
jeans.
weren't. Yeah. So you can have faith in me, absolutely, that I know what I'm doing.
Yeah, 100%. Are there any other questions for Mel? We've got the dates, and we'll, as usual, we'll support Partners in Care with anything, share it round. Just before I do my last few bits, Christiana is going to do, thank God, a very quick talk on delegated healthcare activities, because I was kind of going to read it and pretend I knew all about it when I didn't. So we haven't got loads of time, but I'll hand over to Christiana. You might want to introduce yourself, Christiana, because you've been off for a year gallivanting.
Gallivanting, I wish. Thank you for having me along today. I'm Christiana Evans, and I'm the locality manager from Skills for Care for Somerset and Dorset. The reason I've been off for a year is because I had a baby, so you know, gallivanting would have been far more restful probably. Right, I've got a couple of slides which I will whiz through really quickly. Luckily, I had just done this at a meeting earlier today, so I am a bit fresh on it. Right, so we delegated healthcare activities, big area at the moment. I'm not going to go into all the background and everything, only in suffice to say that as all of our resources, they have been put together in partnership with the sector, with representatives from health and social care colleagues, people with lived experience, regulators, and we have had a expert reference group overseeing all of this stuff, the National Steering Group, which has had overall accountability and direction. It's called the Delegated Healthcare Activities Steering Group, and it's been brilliant to have that led by Deborah Sturdy, the Chief Nurse for Adult Social Care at the Department of Health and Social Care. So all of that information is on the website. ADAS have done stuff to help us out. The Foundation of Nursing Studies have done things, St Martin's Care, all sorts of, there's been a lot of work in the making of this and a lot of activity in the making of these basically. And they're launched today. So absolutely fresh off the press. I don't need to go through in any great detail what we mean by delegated healthcare activities. It's obviously something that is delegated that usually a regulated professional would do, and that will include a registered nurse, a nurse associate, or an occupational therapist. It's not new. We know that this has been happening for a while, and there's no statutory requirement, and certainly in most circumstances, adult social care services are not commissioned to do this or undertake these delegated healthcare activities. The principles that we have produced are voluntary. It's sort of like a best practice guide, really. First and foremost, it's around supporting person-centered care in delegation that is safe and effective, and supporting sound decision making. The framework has been adapted to this framework is designed to be adapted to be used across a range of settings, so that includes the PA workforce as well. And I'll just go straight into what they're about really. So we've got 4 principles here. As I said, it's really focused on person-centered care, ensuring that those delegating decisions always have the person at the heart of those decisions, that they include family members or other representatives where in that decision-making process. And it really prompts you to ask certain questions like, have people had the opportunity to ask questions themselves? Are family members and people involved in those decision making? What is important to the person? How is the delegation appropriate for the achievement of outcomes? And how will they be involved in activities? So it's really, having that person-centered care at the heart of it all. Next, absolutely vital, governance, regulation and accountability, which requires trust between colleagues and health and social care, and working across different health, work boundaries and organisational boundaries. Making absolutely sure that accountability is clear, that everybody has a good understanding of people's roles and responsibilities within the delegation, that there are robust governance structures for providers, that includes regulatory requirements, commissioning, legislation, and then it all has to fit with organisational policies and practices as well. It looks at risk, how risks are identified and mitigated against, and then also really asking those questions about empowering people, making sure that people have the right, or feel empowered to speak up if they're not comfortable about the delegation activity. Next, we're moving on to learning development and the skills and the competency part of it. Of course, that goes without saying around that the person doing the delegated activity needs to have access and needs to, in an accessible format as well, to be able to have the right learning and development, the right skills, that competency and confidence as well. And then with that comes the right level of support, training. Again, going back to that person-centeredness, that the training is tailored to the individual's health and social care needs, and that the outcomes will be achieved through the right training. And then we've got monitoring and reviewing, making sure that that delegation takes place within clinical oversight of a regulated healthcare professional who will take the responsibility for the monitoring and the reviewing of people's healthcare plans, that there are open channels of communication, and that there is that ongoing support as well via supervision. I've mentioned that they're designed to be adapted locally as well across a range of settings, and they're suitable for a wide audience. So what do they look like? This is all up on the website. I'm not 100% sure if the videos are up there yet, but they will be added shortly. So we've got tons of different resources on there to support them. They're not, like I said, they're designed to be flexible and used as you need them in your own setting. It's not that one size fits all approach. It's utilising them in the best way that will suit your needs. The videos include, I'm just going to check, they include an employer of PAs, a falls impact reduction pilot, and experience of people involved in the blended roles programme at Thameside, and a telehealth monitoring case study. So that's them. That's what they look like. And I'm just going to show you very briefly what they look like on the website. I will pop the link in the chat in a moment. Are you seeing that? Am I sharing correctly?
No, I can't see it.
No, I'm not.
No, while you're doing that, Christiana, you can probably see Vicky and I have been kind of talking, but one of the things that for me, supporting providers, my biggest fear is interpretation. What we may be asked to do by somebody who doesn't quite understand what it is. And exactly as Vicky just said, it's training, it's competency, and actually it's commissioning and paying for those things. So we as providers need to be super careful, have a really good understanding of it. It isn't legislated, but as you remember a couple of weeks ago, I was talking about how we'd been asked to comment on how we'd feel about doing wound care, and that kind of starts to link into this. So it's something we've got to be very careful about, where it goes, how we're protected with it, and what we say yes to, isn't it, Christiana?
Absolutely. And I'll hold my hands up. I'm not really familiar with the content of the resource yet. I know it's been a long time in the making, but I would hope that a lot of that stuff is covered in our resources. The decision tree, for example, that should be a really good resource and a really useful one. So all of that stuff, and the examples, like I said, it's voluntary. It's not, and and the commissioning stuff, it's all there. Hopefully we haven't missed anything. If we have, then we'd like to hear back from you. I'll pop the link in the chat now. It should help you to make those decisions and to understand whether it's right to go down that route. And they are also designed to be picked up by commissioners and ICSs, and we will be having those conversations at that strategic level as well with commissioners, local authorities and ICSs to make sure this is picked up, because I said it's not something new, but it's been bubbling for a while now. So great that the resources are there, great that they're useful.
Vicky's got her hand up. Go for it, Vicky.
Yeah, just to say thank you, because this is very much needed. I wonder if there's any resources in the pack that support a conversation with the delegating health professional, so the GP or the nurse, or because that's often where we fall down. They don't realise that
There's
they
a
are.
commissioning pack in there, so I think
Yeah.
that's the bit we need to really read, so we're braced and ready. Mel's just said about a webinar on this, which I think nearly all of us would like to be a part of, you know, whether you're James or Chris from the TAs, you know, it's really critical we understand this, because when things are asked, we don't know what we can and can't say no to. Some of us do. And then the critical bit here is insurance. We've got to, because our insurance companies need to know that this might be something we'll be asked to do, and they may well say absolutely not, or it's going to be another 5 million. So I think
that came up this morning.
Really got to be understood.
It absolutely came out this morning. So we'll be feeding this back, and where I presented it this morning was at our regional community of practice. So leave that with me with the whole webinar thing, because it was a very interesting conversation and it needs to be taken forward.
It does.
We'll respond in some way, whether it be regional, local. We'll yeah, leave it with me.
I'm conscious of time. Does anybody have any other questions before I just do a quick fly through the last few bits from our end? Okay, I will fly through. I've been involved in the new visiting in and out of care homes with John's campaign, and how we are viewed as care providers. It's tough, actually, because there's a very, very dim view of a lot of the care homes, and that we literally deliberately blocked people from coming in during COVID, and that we're still doing it. And there are a variety of things that are being pushed through legislatively, and there are some people in the group who are very willing to understand the difficulties we have, and that we were previously just locked down, there's nothing we could do, and that sometimes we have to take into account other people's views. And some of the documents that are being written are very NHS driven, because it refers to our visiting hours. And we had to say we don't have visiting hours in care homes. You can come and go as you like. It's 24/7. And they were referring to the patients and the nurses. So we're doing a lot of work on it. What I've asked is if I could, the CAA, the Care Association, can have the first draft so that we can share it, so you guys can really have your say on it, because it's critical. And it shouldn't just be about care homes, because actually, you know, Andrew, for example, I know some of his staff do support care homes, so it's about everybody's view. And some of us I've got a brother in a supported living, so I think it's critical. So as soon as I've got my hands on it, I will share it with everybody, and please get your points of view in there. I've already told you we've now got 5 TAs, so they will be doing more visiting to you guys. There'll be more capacity, and sort of just being able to do a little bit more. But also recently there was a conversation where there was some BCP patients, service users in DCH. So we were able to work with them, and we're hoping to do a bit more of that if they come our way. But I do promise you communication is underway in terms of spreading out towards the BCP area. On the amazing WhatsApp managers group site, the one that Mel was talking about, the DSPT late at night on, which is a worry, Mel, you need to go out more. I did say yesterday, I don't know if people want to, but if any of you do want to put some vacancies on our DCA website for families to see, because they're beginning to access it, you can. We'd obviously have to keep it up to date, but if that's something you want to do, we'll do it. So Hannah is available to take that, and we can stick it on there for you. And that's not just care homes, that's, you know, any type of support. So if you've got a supported living vacancy, you've got extra hours available. Oliver McGowan, just a nudge to remind everybody, if you haven't done it or you aren't signed up to it, please get your staff signed up to it. It's really important that you get that done. It's quick and easy, but it really makes you think about what service users with, you know, different needs need you to do for them. Dorset Council are in the process of putting together specialist categories for residential care. They've asked me to comment on it, and actually, yes, as much as I'd like to poke my nose in, great, but there are people here and in the DCA and partners in care groups who should be involved in this. They're looking at different areas, so it'd be residential low need, residential medium need, residential high need, and it's how they're categorised. And actually, for me, people can change from day to day. I could be low need tomorrow and high need the next day. So I think, again, we need to have lots of ability to comment on this. And then there's nursing care and advanced nursing care. But like we've just seen from James, the nursing homes are making lots of calls to Medicare and we're making less. So I think we need to be looking at all of those areas as well. So again, be good to support you on that. See you later, Vicky. Thank you. Last bit, the new CQC monitoring. We've got a couple of links for you in case you haven't used them or seen them. Hannah will send them out later on. The new the feedback on care form, that's a really interesting link. It might be worth using it to start sending out to some of your service users and families now, because you'll start to build up your CQC evidence file. The more you can start getting that file ready for the new format, the better. They're looking, as you know, for evidence surveys, relationship management, and what you can put in that folder. So it might be worth us putting a webinar together with maybe Mel and Kate and Christiana on what you should be beginning to put in there and how they're going to be fact finding. But I do recommend when you get the link from Hannah, just have a look at it and think about sending it out to people just to start to get beginnings of feedback for your file. I think that's it really. Apart from Hannah, we've got a date for the LD forensic meeting. We haven't got many people wanting to attend, having asked for it, which is where we're talking to Karen and some of the commissioners about difficulties that are had at the point of entry into hospital. So Chris will be there, hopefully. I know Vicky's attending, but Martina, it might be good for you to be there as well. For any individuals who come in via ED or onto a ward and the wards just are not understanding how to support individuals correctly. Mel, you might want to attend as well and put your point of view across. What's the date of that, Hannah? Can you remember?
I think it's the 30th. Let me just triple check.
If we can send that back out again, if anybody would like to attend that, because DC.
Yeah, Tuesday the 30th.
Okay, do you know what time? 10, 11, something like that. But I think the more that can attend, the more we can really try and change things for the hospital and how we support them, and the TAs will be there to support that as well. That is it from me. Anything from anybody else that anyone wants to add? Good. Okay, well, it's good to have you back, Christiana. You're now very much a part of the Care Association as well, and we'll keep our bits and pieces coming out to you. Hannah, thank you for all the hard work you're doing at keeping everybody informed, and we will see you in about a month.